Here's an outline of the presentation. We will discuss each topic that we have here on the slide. We're going to go over what's an LVAD, the background of the patient, and just the whole nutrition care process and the summary conclusion. And I'm going to briefly talk about my references, and then we'll leave questions for the end. What is an LVAD? An LVAD is a mechanical pump that is used to support the heart function and blood flow in individuals' left ventricular that doesn't work properly due to heart disease. Its main job is to help the left ventricle pump blood into the aorta, which is the picture on the right. Shows you that the LVAD helps pump blood into the aorta, which is the main artery that carries oxygen-rich blood from the heart to the rest of the body. Who may benefit from an LVAD? The LVAD can support your heart, but there are stimulations of who may benefit and who actually may receive an LVAD. So I provided the 3 top reasons why an individual may benefit from receiving an LVAD. So the first one, during or after surgery while your heart recovers, you may be actually not getting a heart surgery, but any type of surgery, your body needs your heart to pump the blood efficiently. So if your heart doesn't work properly, it can actually help during or after the surgery while the heart recovers. Secondly, waiting for a heart transplant. If your heart, as I mentioned before, isn't working properly, it will help your heart pump and keep going until you may receive a heart transplant. And lastly, if you are ineligible for a heart transplant, not everyone who actually goes for a heart transplant gets one. Therefore, this may help you provide long-term support. And just like, as I mentioned before, not everyone is eligible for a heart transplant, not everyone is eligible for an LVAD. There are certain different reasons why an individual may be denied from getting an LVAD. The first one is may be caused by advanced age. Here at UTMB, the cutoff age is 70 years old. If you are beyond the age of 70 years old, you are not eligible for an LVAD. If you have renal failure or a recent cancer diagnosis, those are also other reasons why you may not benefit from an LVAD. And lastly, if your BMI exceeds 42. I'm not sure at other hospitals what is the BMI cutoff, but here at UTMB the cutoff for an LVAD is 42, and our goal is to keep them around 35. That is the BMI, because we don't want someone thinking that they can just keep going and exceeding with their weight as long as they're under 42. So we do accept people that have BMIs of 42, but we aim for them to have a lower BMI below 39 to 35. That's around the BMI we would sort of accept it. Now we're going to switch it up a little bit. I just wanted to introduce what an LVAD was and who actually may benefit. So I actually wanted to talk and switch gears, talk about our client. Mr. GS is a 70-year-old Caucasian male, so he is actually at the age cutoff. If he was 71, he wouldn't be able to receive an LVAD. But since he is 70, he's actually still eligible for an LVAD. And once he had his LVAD or the placement of that LVAD, he actually started to complain of a decline in appetite. So that's what we're going to talk about mostly in this study. What happened to him after the LVAD? He had a decline in appetite, and we kind of go through this whole case study and look at before and after to see how he came to that part. So his reason for admission, he had shortness of breath and his heart failure was worsening. And I do believe that he, was on the list of getting an LVAD soon, but he was having those issues. His chief complaint, he had sudden onset of shortness of breath for the past 3 days. His length of stay from admission to discharge was 19 days, and that was with the LVAD procedure included in those length of stays. So we're briefly going to talk about the client's past medical history and their past surgical history. It is to actually know what all happened to your client prior to his recent LVAD and just prior to coming to you. This will all help you while you plan an intervention. As a dietitian, you do not want to give him, a lot of carbs in one meal. As we see, he was diagnosed with diabetes in 2011. And he has also hypertension, hyperlipidemia, congestive heart failure. He actually had a heart attack or an MI, and he has CAD as well. Past surgical history on the right, he had a stent placed in 2005. He had part of his kidney removed. He has tonsils removed. And as you see, these last two dates, on the 20th, he had a full mouth extraction. So we do need to be mindful in that when we do create an intervention, that he had all of his teeth removed just 4 days prior to his LVAD placement, which was on the 24th. So here's a brief hospital summary prior to the decline in his appetite. He was admitted on the 19th of March. As I mentioned before, his reason for admission, he had shortness of breath and his heart failure was worsening. His chief complaint, as I mentioned again, it was a sudden onset of shortness of breath, and it worsened over the 3 days. So it actually got worse, and he was noticing that. So he came in. He had a full mouth extraction on the 20th. His diet order after the full mouth extraction, he was placed on a full liquid diet, and they kind of held that out until his LVAD placement, so I'm pretty sure he was a little hungry. He had his LVAD placed on the 24th of March, 4 days after his full mouth extraction, and his diet order immediately after the procedure, he was put on an oral supplement, and he got that via the tube. He had the Promote Continuous that had a goal rate of 60 milliliters per hour, and that provided him with 1,440 calories, 90 grams of protein, 2,800 milligrams of sodium, which is a little high, which he's a cardiac patient, so we would kind of want to be mindful about that, and 1,200 milliliters of water. He also had an additional amount of protein. He had 2 scoops, which provided him with an additional 150 calories and 36 grams of protein. So we're going to briefly discuss his last 24 hours. Within the last 24 hours, it's kind of just giving you a summary of what's going on with the patient after his LVAD. So he's a post-LVAD placement. He got on 24th. He was recently extubated. He was placed on a tube feeding, as I mentioned, and he was on Promote Continuous. He requested a regular diet. When we went to go check on Mr. GS, he was eating ice chips, and he said that he was hungry. So he was actually advanced to a cardiac diet with a regular texture. Now be mindful, as I mentioned before, he had a full mouth extraction. So placing him on a regular texture diet may kind of interfere with how he's eating. And then after that, he complains of a decline in appetite. He's just saying that he's not hungry. And so a dietitian was consulted, and that's where we come in. We want to know why he's not eating, and we may have a little idea just from this 24-hour event. If he had a full mouth extraction and he's given regular texture, that may contribute to his decline in appetite. But we will go further into and investigate and see what's going on. Now let's begin with the nutrition care process. Nutrition evaluation and support in LVAD therapy is very important. It's just everyone has to eat, and we always as dietitians need to be on every team because everyone eats. If a patient is malnourished pre or post surgery, it may complicate things after the surgery. They may have infections. They may have slow wound healing if they're not getting the amount of protein. A lot of situations may happen if they're malnourished pre or post. Therefore, it is important as a dietitian to be included on these teams to manage the patient's nutrition effectively. And here's just a little side note. Early recognition of undernutrition through nutrition assessment, that's what we're going to talk about next, could possibly affect the long-term prognosis of these patients. And it may enable an early intervention, and you may be able to come in and intervene and actually prevent or treat these issues that may have caused from the malnutrition. So we're going to begin with the nutrition assessment, which is the first step of the nutrition care process. One of the things that we look at during a nutrition assessment is a physical assessment. As a healthcare professional, we all use physical assessment for different reasons. As a dietitian, we look at different things other than as if we were a physician or a nurse or a respiratory therapist. We look at the three things that are bolded. We ask them about their GI to see if they have any GI problems, and our person actually denied nausea, vomiting, diarrhea, constipation. But as I mentioned, he does state a low appetite due to fatigue. His wounds are dry and they're intact, so there's no need for the additional protein. And his extremity, he does have, especially in his lower part of his extremity as far as his legs, he has a mild trace edema. We also look at the weights. As a dietitian, we are responsible to monitor the patient's weight. Below, I have provided some weights before the complaint of decline in appetite, and we're going to compare this to the patient's weight at admission. So he was admitted on the 19th, and he was 75.9. The day of the procedure, on the 24th, he was 72.5. And that weight loss of the 3.4 between the time of admission and the day of the surgery, it could be from loss of appetite. Since he was on a full liquid diet, he could have just been losing weight from that, or the excessive fluid that he may have had prior to surgery. But there's a weight gain 5 days later of 2.7 kilograms. So it could be a lot of things that's going on with his weights, and we kind of don't know yet until we go in and kind of speak with him. Mr. G was prescribed to 7 medications prior to his admission, but I wanted to highlight 4 medications that he was placed on prior to his admission. So here is his medications listed below: Lasix, Chloride, Extra Strength, and Novolam. I'm going to go over each of them briefly, and then I'm going to talk about Lasix a little bit more in detail. That's why it is bolded. So first, Lasix. He was taking 10 milligrams per milliliter injections. You can also take Lasix via mouth, but Lasix treats fluid retention and high blood pressure. He was also on Courage, which he was taking 25 milligram tablets. This treats heart failure and high blood pressure. He was taking extra strength Tylenol, and that's basically to help relieve pain that he might have had. And lastly, he is a diabetic, so he was taking Novolam, 100 units injection, and that just lowers the amount of glucose in the blood to treat diabetes. So if anyone just has high blood glucose in the bodies, this will help lower the amount of glucose in the blood. So going back to Lasix, when you inject this medication or take it via mouth, it causes diuresis, which is increased urine output to decrease excessive fluid. A reason for his weight fluctuant and or weight loss, previously described in the previous slide, could be due to diuresis as a result from the Lasix. So his weight fluctuant that I just mentioned before, the 6.8, I believe, kilograms, it could have been due to the Lasix. It was actually put into use, and the extra fluid was actually excreted from the body, which has maybe caused the weight loss. We also look at his weight as of now. So as of the 30th, which is the day he States a decline in appetite. He's 165 pounds or 75.3. So he's around the weight that he was when he was admitted. And his BMI is 22. As far as the elderly population, we like them to have a BMI around 23. So he is a little bit under, but he still falls in that normal category. As far as an ideal body weight, 24.9, he would be about 83 kilograms. But for an elderly patient, he's sitting in kind of a good spot right now. So we kind of want him for his weight to be stable so he can stay in that BMI range. We also look at their lab values. Lab values help us determine the current status of the patient. The next slide, I will present specific labs that we look at for an LVAD patient, and we're going to compare these to the reference range. And this is all prior to the decline in appetite. There will be bolded numbers, and they will either be below or above the reference range. Here we have a lot of different lab values: sodium, potassium, BUN, creatinine, calcium, phosphorus, magnesium, glucose, iron, and albumin. These are all important lab values that we look at. And right next to that column is the reference ranges, and then next to those are the 3 days that we looked at, and these are all prior, except on the day, the 30th was the day he did complain of the decline in appetite. This is sort of kind of how his lab values were looking prior or up to that day he started to complain of decline in appetite. As we can see, all 3 days his sodium levels are low. They are pretty low, but they're not extremely low, so we can actually just keep an eye on that because they actually start to rise, and he's starting to get closer to the reference range. So something may be going right. As far as his BUN is pretty elevated, and it continues to rise, and then his glucose on the last 2 days, they are a little elevated, but he is diabetic, so that is kind of considered normal for him, but we still want to keep it closer to the reference range, as close as possible, so it doesn't cause any more complications. So Mr. GS has specific lab values that were pretty significant, and below are just brief symptoms of low or high levels of those specific lab values. So his first one was low sodium levels in the body, and as I mentioned before, they do kind of continue to rise. But they can cause loss of energy and fatigue, nausea, vomiting, muscle weakness, muscle spasms, or muscle cramps, also as well as seizures, or lead to comas. The BUN, which a high BUN level in the body suggests that an impaired kidney function is going on, and this is caused by a decrease of blood flow to the kidneys. And these reasons of why the blood flow is really low in the kidneys is caused by congestive heart failure, something that we know that Mr. GS has. So that could be a reason why his BUN is elevated. And symptoms include fatigue, lack of confidence, poor appetite, and trouble sleeping. And as I mentioned before, he did mention of a fatigue. That's why he declined in appetite. And as you can see, his sodium is low and his BUN is high. And fatigue is symptoms for both of those. And lastly, he has excessive glucose in the body. And that can cause frequent urination and excessive thirst. And that also could be a reason why his sodium was low. If he's taking a lot of fluid, this could be lowering his sodium levels in his body. And here's nutrition assessment. All these days we went to go see the patient. On the 24th, the day of the LVAD, he was placed immediately on a tube feeding to promote with a go rate of 60 milliliters per hour. On the 27th, he was tolerating it fine. He was also tolerating ice chips, and he had the additional protein to promote wound healing. And when we went to go see him, he was eating his ice chips, and he was telling us that he was ready for a diet, and he was ready for his diet to be advanced. He wanted to actually eat his food. So on the 29th, his diet was advanced to a cardiac diet with a regular texture. And as I mentioned before, please note that he underwent a full mouth extraction 4 days prior to the LVAD placement. And he reported of eating barbecue chicken, he had cereal with 2% milk, and he had banana pudding. And then on the 30th, he states that he has a decline in his appetite because his food is too tough to chew, which causes him fatigue. He mentioned he has to break down the food, and it's just he gets so tired from just chewing on the same piece of food for a long amount of time that it just causes fatigue, and he just doesn't want to eat anymore. He reports of eating a breakfast sausage, toast, yogurt with strawberry, and a tortilla with some shredded chicken. So after I looked over everything and I reviewed his weight, I reviewed how he was eating, I reviewed his lab values, I was able to come up with a nutrition diagnosis, and I came up with suboptimal oral intake related to the full mouth extraction to remove all teeth prior surgery, as evidenced by reports made by the patient of a decrease in appetite because their food texture is too hard to chew. As I mentioned before, the last time we went to see him and he complained of the decline in appetite, he just mentioned, I cannot eat well because my texture is just too hard for me to chew and I cannot eat it. I need something different. So we know that his diet needs to be changed. But before we do that, we need to know how much he's eating, or how much calories he will need, protein, and his fluid as well. So we came up with a nutrition prescription based on the Mifflin St. Jeor and a activity factor of 1.2. We came up with 860 calories per day, 0.8 to 1 gram of protein per kilogram. We came up with 60 to 75 grams of protein. And lastly, his fluid intake around 18 to 1900 milliliters. But we do leave that at the MD's discretion. If they want to change it, if they want to move it up or down, that's something that we will let them do. We basically just provide a number for them to loosely base off of. So we come up with a nutrition intervention. The first one, we want to recommend to change the texture of the diet from a regular texture to mechanical soft, just so it can be easier for him to chew. Second, start a calorie count. We want to monitor how much calories he's taking in a day, so we won't see that sort of weight going up and down. Also, we would like to recommend Ensure Complete twice a day between his meals, just to provide to ensure he gets its adequate caloric intake. He may not eat everything on his plate, so if we actually provide those ensures twice a day, maybe between his lunch and after or before his breakfast, or whenever he would like to fit it in his meals, that will give him the additional calories. We want to monitor his daily weight. If he's having a decline in appetite and it continues to decline, we may start to look at if he's losing weight. So we want to keep an eye on his weight. And lastly, we want to provide the patient with post-LVAD transplant education prior to discharge, because he just had this LVAD placed, and although he does have a decline in appetite, there's much more that we need to discuss with him as far as nutrition before he leaves. I want to briefly discuss what's all included in the post-LVAD education. We have the cardiac diet, which is for all heart patients. He's also a diabetic, so we have to be mindful of that. Low sodium, low cholesterol, fresh fruit and vegetables. Healthy fats, also throw some carb counting in there. We want to increase or continue his physical activities. We want him to stay within his normal limits of BMI and just to decrease complications of the LVAD. We're not worried about him gaining a lot of weight and, shooting off and, having a BMI of 50, but we want to be mindful that he could possibly fall off. because of his decline in appetite. We don't want his BMI to go any lower. In addition, we just want his heart to keep pumping and, get his heart stronger. And his physical activity will be approved by his physician. They'll talk a little bit about it, see what he can and cannot do. That will go into further, but we just sort of encourage it. We talk about the cumin and vitamin K interactions. All LVAD patients are put on a blood thinner, and we just want them to be mindful of staying consistent. Many of these patients are already on cumin, so many of them have it down pat, but we sort of just reiterate the idea. If you have 3 greens a week, keep having 3 greens a week. Don't fall off, don't eat less, or don't eat more and more. Just stay consistent. If you don't eat greens at all, don't worry about it. The dark green leafy vegetables, do not worry about it. And lastly, food safety. You have a foreign object in your body. Therefore, it's important to know that you can get sicker much faster than others. So that's just something to be mindful about. And these are the goals for each intervention. Goal for intervention 1, which was to change the texture, was just to provide the patient with softer foods to consume, just so he can increase his caloric intake. This paper by Bolhus actually just described that patients that had harder foods, they actually consume less calories, so they provided them with softer foods and it actually increased their caloric intake. Goal for intervention 2, which was to start a calorie count. This was to monitor and analyze food intake. When you think of calorie count, you think of just counting your calories, but this is totally different. We want to start the calorie count to analyze his food intake. So, with the hopes of improving his caloric intake and ultimately weight gain. And as I mentioned, we want to have everything that he's eating, and we kind of just analyze it. We see what he's eating, what he's not eating, so we can improvise his diet and get him to eat more and eventually lead to weight gain if he's losing the weight. Goal for intervention 3 was to provide the Ensure twice a day. That was just to increase his total daily calorie intake. If he's not eating because his food is too tough, or he is eating but he's not eating enough, this is just to give them a little bit more. And this paper talked about how just oral supplements just provided additional calories and it ultimately improved their weight gain. And I mentioned weight gain just because as we look further into his weight, it fluctuates, and we just want him to be in a nice BMI range. And lastly, for goal interventions 4 and 5, which was to monitor weight and LVAD education, to provide those 2. I know I mentioned a little bit about weight gain, but as we'll see, that his weight goes up and down and is not pretty stable. So this is just to ensure safe and adequate nutrition and to remain within a BMI to decrease post-operative complications. So if he does gain a little bit of weight, we actually won't be too afraid because he is at 22 BMI and he has that cutoff of 24.9. But we ultimately want just a little bit of more weight gain so he can be around the ideal body weight or the ideal BMI for an elderly person, which is 23. And this paper here, the Colger, it sort of just explains how they did a study and these individuals had an LVAD transplant and they put them in 2 different groups. The ones that had the intensive education and all of that, they actually had just better outcomes. Their BMI remained within the range. They were eating better. They just had outstanding outcomes compared to the individuals that had just a brief do this, do that, and send you on home. So it just all depends on what you give these individuals. So monitor and evaluation plans. Every day we rounded with the team. It was not a day where we didn't round. Although we didn't write notes every day, we did monitor with the LVAD team daily. We rounded all the time, and this was just to monitor intake. After the recent texture change, we went from regular texture to mechanical soft. We wanted to monitor the intake from their calorie sheet. We want to monitor his daily weight via the medical records because it was going up and down, and we kind of want it to be stable, and then we kind of want him to gain a little bit more weight just so he can be closer to the ideal BMI of 23. And we want to monitor for any abnormal lab values that we saw earlier. He had the elevated BUN, the low sodium, and the high glucose. And if necessary, we will revise the nutrition intervention that we provided as changes occur, because things won't always stay the same and you always have to improvise and just make things a little bit better. So this is the results of monitoring. This is us days and days of just following with the teams of what we saw. So this is his events that was post his complaint and the decline in appetite. His diet texture was changed to mechanical soft, cardiac diet, and a calorie count was initiated. They did not start the Ensure Complete. They have it, but every time we went to his room, he never received it. So they never really gave him the Ensure Complete, but it was placed, the order was placed. But as I mentioned, his diet texture was changed to mechanical soft, and a calorie count was initiated. And the calorie count is a simple piece of paper, and it has breakfast, lunch, dinner, and the date. You write, 0, 25, 50, 100% of how much he ate of each food. So this is the calorie count from the 3rd of April. He had 2 pears, 4 ounces of orange juice, 25% Popeye, and as you can see, these are all pretty much soft foods, except I guess the chicken pot pie, the hard crust at the top, but mostly it's a soft food. So for that day, he had a total of 1340 calories and 35 grams. And based on this calorie count, he's meeting about 70% of his needs. His needs was 1860, and he had about 58% of his meeting his needs of his protein. And as we mentioned before, we recommended 60 grams, so he's getting about 58%. And we will continue to follow and analyze this 3-day. So we're going to look at 3 days, and this was day 1. Day 2, more food is on here, but and is continuing to be more soft foods. He has mashed potatoes, pudding, jello, mashed potatoes again, milk, fruit. It depends on what fruit. I'm guessing it was stuff in like the fruit cup, a lot of glasses. He had a candy bar, and he had some turkey. He had about 1763 kilograms that day, which was about 95% of his estimated needs, which is very good. That means he's actually eating. If he had that Ensure Complete, he would have been right there. And he had about 100% of his estimated protein needs, which is wonderful, because we want to promote the wound healing from the recent LVAD. Day 3, a little less than day 2. Day 2 is his biggest day. He does like his candy bar. It's the second day, but he eats all of it. Orange juice, coffee, a lot of liquids, soft foods, mashed potatoes, pudding, and 2 ounces of iced tea. So he gets 1100 calories a day, around 6%, and then 20 grams of protein, which is pretty low from his other days, which gives him an estimate of 33 estimated protein needs. And that was the 3 days that we analyzed. And like we mentioned before, that Ensure Complete would really do him some justice, because Ensure Completes provide about 300 to 350. So if he has 2 of those, he would definitely be meeting or close to meeting his needs for those Ensure Complete, and a little bit higher protein he would get from that as well. As I mentioned before, it is important that we monitor his weight, and there is a decline in weight from his admission. From his admission to the weight at discharge, he was 75.9, and at discharge he's 69.1. That is a really big big amount of weight being lost. This weight loss can be caused by a loss of appetite, all the diet changes, or excessive food, or it could be caused by all three. And this is something, as I mentioned before, we sort of see these things a lot, even though their kind of weight is stable. We always see a decline in weight towards the end because, I mean, they're trying new things, and it's difficult. Sometimes it's difficult for them to eat. They don't want to eat because they have pain. They don't want to eat because they can't eat. They don't have teeth for it. It could be a lot of reasons they can't eat because they're not recovering well from their LVAD procedure. So we do see a lot of weight loss with these LVAD patients, and I think one of my biggest things is to just provide the education, provide all we can, the ensure complete, to get the additional calories. Just provide those things. We're going to also look at his lab values, as I mentioned before prior, and now this is post decline in appetite. So bolded numbers are either below or above the reference range. And we have the sodium, and as we see, the sodium is still low. And at first it was 131, and it got all the way down to 126. But it has risen a little bit to 133. His BUN was a little elevated, but it did continue to trend down in the downward area, and he's quite around normal now. But we're just going to briefly discuss each of those again. As I mentioned before, the sodium can cause loss of energy, fatigue, nausea, vomiting, muscle weakness, cramps, spasms. It can cause a lot of things. And as I mentioned earlier, high BUN can be caused by decreased blood flow to the kidneys, which is caused by congestive heart failure, which is something that he has. So after reviewing the results of moderating, the dietitian and I, we provided our recommendations. I'm going to continue with the mechanical soft diet and choose some foods that are soft. To continue with the calorie count, to analyze food intake. We kind of just want to see a little bit more of what he's eating, and as we notice, he does eat a lot of soft foods and drink a lot of liquids. We do want to up his protein a little bit, or to continue or start with the ensure complete. I say to continue because it was placed as a diet order, but he was never given the ensure complete. And with him being a diabetic, you could also give him glucerna. Between his meals, his glucose was a little elevated, but it wasn't in the 200s. It wasn't past 200. It wasn't 250. It was 142, but it got down to 127. So I think it would be okay if he had the ensure complete. But if he's really strict with his carbs and he would like the glucerna, that would be a great alternate to it. It just depends on how he feels and what he feels is best for him. Summaries and conclusion. These are points that I just wanted you to remember. And LVAD, that's the main machine that we focus this whole case study on, and it is used to support heart functions in individuals with heart disease, and it's just to help their heart function properly. A dietitian plays an important role in managing the patient's intake, and this is pre, post, long after the LVAD placement, and this is just to improve the clinical outcomes. As I mentioned before, if they're malnourished pre or post surgery or LVAD placement, it could actually just complicate post-operative just situations, as I mentioned before. So as a dietitian, you want to be there from the start and use the nutrition care process. That was my next point to remember. It's just important that this NCP, it helps determine an appropriate intervention for the LVAD patient. And after you provide the intervention, you want to monitor. You want to keep monitoring because, as I mentioned before, not everything stays the same. And it will change, and you will need to improvise an intervention to match the patient. And that concludes my study. These are the different references that I use. I continue to just show you all the different ones that I have, all from the different papers. And here are the last ones. I just want to say thank you for listening to my presentation, and please provide questions, comments, and I will definitely get to you guys. Thank you so much.